Right, good evening everyone and welcome to our webinar on treatment for knee osteoarthritis. Now my name is Damien and I'll be your host for this session. I'm joined by our presenter, consultant orthopaedic surgeon, Mr. Matthew Oliver. Now this presentation will be followed by a question and answer session. So if you'd like to ask a question during or after the presentation, please do so by using the Q&A icon, which is on the bottom of your screens. Now, this can be done with or without your giving your name, but please note that the session is being recorded if you do provide your name. If you'd like to book your consultation, we'll provide contact details at the end of this session. So now I'll hand you over to Mr. Matthew Oliver, and you'll hear from him again shortly.
Thank you very much. Good evening, everyone, and welcome. I'm going to talk to you tonight all about treatments for osteoarthritis of the knee. So a little bit about myself. I'm a consultant trauma and orthopaedic surgeon. I qualified from St George's Hospital Medical School back in 1998, and then did my basic surgical training in Kent and Sussex, followed by my higher surgical training in the South East Thames region, again really in Kent and Sussex. I worked at various hospitals, some district general hospitals and some major trauma hospitals. Once I got my final exams, I went on a year-long trip to the University of Calgary in Alberta, Canada, where I did an adult hip and knee reconstruction fellowship. This was a fantastic opportunity to work in a different healthcare system with some very world-renowned arthroplasty surgeons. I returned to the UK in 2010 and became a consultant at East Kent Hospitals. And I started working here at Benenden in 2012. I would consider myself as a reasonably high volume hip and knee surgeon. I certainly do double the national average of my peers in both hip and knee replacement surgery. So included in this session, it's going to be in 5 parts. The first is all about osteoarthritis of the knee to set the scene. I'll then spend some time talking about synovial pain because that's key when discussing the different treatment options. We'll then follow with a discussion about knee replacements, both the standard conventional knee replacement and the robot assisted knee replacement, which has been here at Benenden for several months now. And we'll conclude with a question and answer session. So what is osteoarthritis of the knee? Well, it's a medical condition of wear and tear. There's nothing we can do to stop it. It is incurable, and it will affect all of us at some point in our lifetime to various degrees. A normal knee, as you can see in the diagram here, is covered with pristine cartilage, which reduces friction in the joint when the femur and the tibia move against each other. You'll also notice between the femur and the tibia that there's some padding there known as the menisci or the shock absorbers. They cushion our every step and enable us to perform quite wonderful athletic pursuits in our younger years. But unfortunately, from about the age of 40, 45 onwards, these menisci start to perish. They develop little micro tears within them, and they all join up and form larger tears, and the menisci lose their plumpness and their shock absorbing ability. And when that happens, more load is placed on the articular cartilage, which then starts to fragment and break away, as you can see on the other diagram next to the pristine knee. Over time, the cartilage area of loss increases, and the knee starts to mechanically deteriorate, and that's when it starts to present to the patient with symptoms. So the early ones are really noticing a bit of morning stiffness, discomfort when you exert yourself. It might be something like crouching down for a while or kneeling for a while or just rushing around. You'll just notice a bit of an ache. You may also have the sensation of the knee clicking and grinding, and notice that it's a little bit puffier than usual and may have some local warmth within it. As symptoms progress, as the disease process progresses, unfortunately, the amount of discomfort and the annoying issues with regard to arthritis sort of manifest, and these are pain at rest after a busy day. It will throb when you're resting in the evening. It may disturb your sleep. It will wake you up when you roll over in bed. You may also notice that your knee is changing shape. You may not be able to fully extend it. You may notice it's becoming bow-legged or knock-kneed in its shape. Along with these things, your walking distance will also decline, as will your athletic prowess. So that's the late symptoms and signs of knee osteoarthritis. The treatment options at the beginning are all non-surgical. As I said earlier, we can't cure the problem, but we can certainly slow down the process. We slow the process down in 3 ways, really. The first is to modify our activity, which isn't ideal, but we just have to understand that the knee is no longer like it once was, and it needs to be treated a little bit more respect and care. So the more vigorous, heavy impact activity won't help the arthritic knee. If we're overweight, that it is crucial to do one's best to reduce our weight, because there is no doubt that carrying extra pounds almost certainly will speed up the demise of your knee. It is categorically proven to be the case. Contrary to belief, physiotherapy is actually handy for an arthritic knee because it keeps it supple, and all the muscles around the knee are kept in good shape, which helps you when you're walking on uneven ground. The knee will steady itself due to good, strong muscles around it. And of course, we've got painkillers, starting off with the simple things like paracetamol and progressing to the strong stuff like cocodamol, and maybe even stronger, the morphine-based tablets. Knee strapping and braces, they really have a limited role, but certainly can be utilized. The braces are a bit cumbersome and clunky, but in certain individuals, they do seem to have a role to play, because you can get an unloader or an offloader brace that jacks out the joint to stop the two surfaces from touching each other, where the cartilage between them is wearing away, and that can provide a degree of pain relief. Non-steroidal anti-inflammatories, for those who are able to take them, are also quite handy. And then we've got a whole selection of different injections, and I'll talk about those more in some detail later. So synovial pain, this is an important concept to understand, because one of the treatments I'm going to discuss with you guys this evening is all about trying to switch that pain off. So in a healthy knee, you have a synovial lining that provides nutrients to the joint and just minds its own business, really, and has a helpful function in maintaining the environment inside the joint. However, if you have an injury to a knee, it could be a cartilage injury or an ACL rupture or a fracture to the bone that needs to be treated, then the synovium gets irritated, and that's the case in osteoarthritis as well. And the synovium goes into overdrive and proliferates and produces chemicals that go into the knee that cause an inflammatory reaction and erode the cartilage, make the knee swollen, warm, stiff, and just generally miserable and uncomfortable. There's strong evidence to show that if this process is allowed to continue, then it can actually lead to a rapid increase in cartilage loss in osteoarthritis, and quite scarily in joints that aren't arthritic, so those knees that have had an injury before the onset of wear and tear. So bringing us on to the first injection I'd like to talk about is called Arthrosamid hydrogel, and it was introduced here at Benenden a few months ago now, and it's gaining momentum. It has been around for several years, particularly in European clinics, and it has increasing scientific evidence behind it to show that it is making a difference in the mild to moderately arthritic knee. And essentially, it's a compound, an implant that is non-biodegradable, that's injected into your knee. It's actually 97.5% water and 2.5% of a hydrogel called polyacromide. And it's this component that combines with the inflamed synovial tissue in your knee and downgrades the inflammatory response that I was talking about in the previous slide. And because of this ability to switch off all those horrible inflammatory mediators, it reduces the discomfort in your knee and decreases the joint stiffness and enables you to have a more comfortable knee. It's purported to last up to 4 years, and there are certainly 3 studies that are ongoing that show promise. One of them up to about 13, 14 months, the other one up to about 2 years, and then the third study up to 4 years. It's not a magic bullet though. You will still have some discomfort in the knee, but hopefully a lot less. Perhaps you won't need as much analgesia, and your activities will be able to be a little bit more exciting than just routine daily life. So it's carried out as a day case. You have antibiotics provided to you an hour or so before the injection, and these are oral antibiotics. Local anaesthetic is initially used in the around the injection site, and then the knee is examined using an ultrasound. We're looking to see if there's a collection of fluid in the knee known as an effusion, and that normally hangs around in an area called the suprapatellar pouch. If there is an effusion, we do our best to drain it to dryness first, and then once we know that we're in the right spot, 6 injections are performed through the needle, one at a time. Each syringe only has 1 milliliter in it. And you may wonder why there are 6 syringes, and this is because it's quite a viscous sort of gooey material, and doing it in one big syringe would require quite a lot of plunge power, I guess. So it's easiest to do it one at a time. After the injection, it's advised to have a restful 72 hours and avoid strenuous activity for up to 2 weeks. And we say to patients that they may have some increased discomfort in the knee for the first couple of weeks. There's a rehab program available as well with this injection therapy, and information on that can be found on the company's website and also in the brochure that's provided for you. There are minimal side effects associated with Arthrosamid. It's actually been around for many years in various guises in different branches of human medicine. So it has a 20-year safety profile, and there have been no reports of any serious side effects. Apart from what I've just mentioned, you can get some mild joint pain and swelling for a few weeks. And of course, with any injection, there's always the risk of the introduction of infection into a joint. And that's why it's done under strict aseptic technique in a minor operating theatre or an operating theatre. And the patient is given antibiotics prior to the injection to minimize this risk. The next injection available here at Benenden is an injection of Durolane viscosupplementation. As a member, you can have one of these per membership cycle. It's carried out as a single outpatient injection of a chemical called hyaluronic acid. All of our joints have hyaluronic acid in them, but as we age, unfortunately, the amount and concentration starts to dwindle. And hyaluronic acid has a really important role to play in lubricating the joint and reducing the friction between the surfaces as they rub against each other. So Durolane is essentially a synthetic hyaluronic acid boost. I say to patients, it's a bit like an injection of Castrol GTX. It really sort of reduces the pain by increasing the lubrication. It doesn't work for everyone, but it's usually quite successful in the mild to moderately arthritic knee. It can be repeated, and I've seen it on many occasions that people do return for further injections, especially at the beginning of the ski season, it seems. So the final one that we can entertain or utilise here at Benenden is the tried and tested local anaesthetic steroid injection. Again, it's carried out as an outpatient procedure, and you can have 2 to 3 of these per year. Again, it's effective in the mild to moderately arthritic knee, and again, all the risks of infection still persist. So it has to be done with strict aseptic technique. It is not suitable for everyone, and it should be avoided in those who have diabetes, as it can cause your blood sugars to go a bit haywire. The only other caveat with an injection is that if you are on the verge of needing a knee replacement, then it's probably best to avoid having it done, because most surgeons would delay knee replacement surgery for at least 6 months following the injection. This is because there is some evidence to show that having your knee replaced too soon after injection puts it at risk of a deep periprosthetic infection, which is a bit of a nightmare, really. So moving on to the surgical treatments now. The first one is osteotomy, which isn't carried out here at Benenden. It's only really done in a few specialist centres, and it's usually carried out on the younger individual when the very, very early signs of arthritis are noticed, and when there's a malalignment issue with their anatomy. The surgeon effectively fractures the bones in a controlled manner and resets the alignment of the leg to offload the area that's taking the strain. It's high morbidity associated with it, with a lengthy recovery time, but if done correctly, the results are actually quite encouraging and may put off the development of osteoarthritis for many, many years. Arthroscopic techniques, so keyhole surgery to the knee, this is mainly frowned upon now for the arthritic knee, and lots of studies have shown that it is a sham procedure. There's no point just washing the arthritic knee out and debriding it, because it will only give the patient temporary relief, and sometimes could actually in fact make things worse. There are a few indications though for arthroscopic surgery in an arthritic knee. For example, one of them is when you have a loose body of broken off bone that's floating in the knee that causes the knee to jam or lock or give way. It's a good idea to fish this out through the keyhole to relieve those mechanical symptoms, so the patient can then have better function in the knee. The other indication is an unstable degenerative flat tear of the menisci. Those flat tears can get stuck like a spanner in the works, and they're usually caused by an innocuous injury, such as twisting in the kitchen when you're going from one sideboard to the other, and they can be really troublesome. So snipping those out can relieve quite a lot of issues for the patient and give them medium-term relief. But unfortunately, as mentioned earlier, the arthritis continues in the background and further pain will eventually happen. Microfracture is another technique that is carried out through the keyhole, but it's sort of dwindling in popularity now. And this is when little drill holes are made in small areas of full thickness cartilage loss in the knee, in the hope that that stimulates fibrocartilage to grow, which is the next best thing to articular cartilage. It's quite a headache for the patient, because they have to remain touch toe or non-weight bearing on their leg for about 8 to 10 weeks while this fibrocartilage grows over the defect, and is only really been shown to be effective about 60 to 70% of the time. So it's not routinely recommended. Cartilage transplantation, again, really still only at specialist centres, and still is being trialled, really. It's not available in the mainstream, but there's some promise for this in the future for sure. And then we move on to knee replacement surgery, which encompasses the standard technique and the robotic assisted technique. And of course, there are various guises of knee replacements. You can have a partial knee replacement, which is when you have just a part of your knee replaced, or a full knee replacement. So we'll mainly be discussing tonight about full knee replacements. This is a common operation, and approximately about 100,000 are performed in the UK per year. The average age of the patient's about 69. Most of the patients are female, and most of the patients report good health improvement following a knee replacement. With the new modern techniques and materials being used, quite a large proportion of knee replacements can be expected to last at least 15, 20, 25 years, everything being equal. So what are the aims of a knee replacement? Their primary aim is to relieve pain. There's no point having it done if just for a bit of instability or the occasional ache. The indication for a knee replacement is pain, 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 pretty much all of the time. It's a good operation for that. It will increase the patient's mobility and hopefully restore a degree of function and realign the leg's mechanical access to the individuals. We have to be very careful with the younger patient, and really the younger patient for knee replacement is in the age band of about 50 to 65. Lots of studies have shown that there's a high dissatisfaction rate following knee replacement surgery in that cohort of patients. So it can be up to 19 to 20% in some studies. So they require a lot of counselling to manage their expectations. The knee that's used at Benenden Hospital is called the Vanguard knee. It's made by Zimmer Biomet, and it's been around many years. It has a very high ODEP rating. ODEP stands for the Orthopaedic Devices Evaluations Panel, and it's an independent body that assesses all of the implants that are used in the orthopedic world, not just knees, but hips, shoulders, ankles, and so on. The NHS are very, very keen on ODEP, and you can't have a knee or hip replacement utilised or regularly used in the NHS unless it's hit an ODEP rating of at least 10. And that means that over 95% of the implants are still going strong after 10 years use. So it's got a good clinical heritage. In our practice, we use the fully cemented knee replacement, and we can replace the patella or resurface it, or we can leave the patella alone. That is an individual assessment done by your surgeon. So what's the recovery like? It is a painful operation, and you mustn't underestimate that. But with modern anaesthetic techniques and using the enhanced recovery protocol, it is getting better and better all the time. Certainly the first 6 to 8 weeks is tough going though. So you'll have a couple of days in hospital usually, and you have a private room of your own en suite. The knee will be bandaged overnight, and then the following day that heavy bandage is unwrapped to provide to show you a protective dressing on your knee, and that dressing should ideally be left alone for at least 7 days. You'll be provided with plenty of pain relief once the spinal anaesthetic is worn off, and ice therapy is good at removing the swelling from the knee. The physio team will visit you daily and help you get up on your feet. The knee replacement is designed to weight bear on fully from the offset, and you'll be encouraged to do that. You'll be encouraged to start bending it. The nursing staff are on hand as well to make sure that you remain well hydrated and your needs are all met. We'll only let you go home once you're safe. You need to show the physios that you've ticked all their boxes, and one of the tests is to go up and down the stairs. You'll be provided all the kit you need to go home with, frames or crutches if required. And in our experience, most people are able to walk around their own environs with sticks after a week or two. So you're reasonably active quite early on, albeit in some discomfort. So breaking it down into time frames, First 2 weeks, you'll be regularly taking your painkillers. You'll notice that your leg will be swollen and significantly bruised. It will go all the colours of the rainbow, and it will hurt. Despite this, you have to work hard on your exercises. It is literally no pain, no gain. If you let scar tissue take hold and win that race against you getting movement, then it's very difficult to undo that. So the take-home message is to just get up and running with those exercises as quickly as you can. By 6 weeks, you'll be back to driving, hopefully, and you'll have a follow-up appointment with your surgeon where your progress will be checked. You'll be able to see your x-rays, and we will be able to indicate to you whether you need to up the ante with the physio or just encourage you to keep doing the same. It will take up to a year to fully recover from a knee replacement, and the crucial period really is the first 6 months, and it is important that you keep on with those exercises as you gradually return to normal activities. There are risks. During the surgery, you can bleed, but it's incredibly rare that a patient needs a blood transfusion after a knee replacement. We can fracture the bone, nerves can get injured, and it's quite common to have a bit of numbness over the scar site, but that usually gets better. Very rarely you can get a foot drop, but again, that normally recovers. Very rarely an important vessel can get injured, which may require repair. We have to be extremely careful during the surgery we don't damage any of the ligaments we wish to retain, nor damage the patellar tendon, but there is a degree of risk involved. During the recovery, you can have some problems with the wound, so it's important that you're in good physical shape before the operation. If you're a smoker, you've got to really cut back on that because smoking affects wound healing. You've got to ensure that you keep it clean and dry and covered so you don't get any infections. But you can get a wound infection on the scar itself or a deep infection. A wound infection we can normally get sorted with antibiotics, but a deep infection, which happens about 1% of the time or less, is a tricky situation to deal with. We'll give you blood thinning medication to reduce the risk of a deep vein thrombosis and pulmonary embolism, but they still occur. You'll have a bit of a limp and, of course, stiffness and swelling unless you get cracking with the exercises. The late complications that can happen are infection, and the late infection normally happens due to a blood-borne infection. You may have a waterworks infection or a chest infection that gets into the bloodstream and lodges in your knee. There's nothing that you can do about that. It's just one of those things, and unfortunately it's very rare. Over time, the implant will gradually wear out. You may find that it becomes a bit wobbly and less stable with time. You can also have a trip or a fall and injure one of the ligaments that stabilize the knee, that puts it at risk as well. And of course, there's always the risk of having a fall and fracturing the bone around a knee replacement, which will need remedial work. So moving on to the ROSA now, or the robotic surgical assistant knee. This has been available at Benenden now since I think it arrived around December 2023, and it started to be used mainly a few months later. We all had to go on various courses to get the accreditation to use it. I went to Cologne for a couple of days with the Zimmer Biomet team, and was very fortunate to be able to perform the ROSA knee replacement with some world experts on cadavers, and that was a very worthwhile experience. So in essence, it's an adjunct to help the surgeon provide a more tailor-made knee replacement for the patient, and to minimize or reduce surgical error, which can happen with conventional techniques. The other thing I'd like to say from this slide is that those who sign up for the ROSA knee also get signed up to the My Mobility app, which is an app you can have on your Apple Watch or iPad or iPhone, and it's absolutely golden. It's like having a physiotherapist with you 24 hours a day. That may sound a little bit scary, but it actually encourages you to work hard on your exercises to get the best out of your knee, and you follow it for a whole year. At various times throughout the post-op period, you'll also be asked to fill out functional outcome scores, which are fantastic resources for audit and research purposes, and help us to see whether the ROSA robot is actually making a difference or not. And the other key about the app is that your surgeon can remotely log into it to see how you're all getting on as well. And I've certainly found this very useful. So I would really encourage you to embrace that technology. So a little bit more about the ROSA. It offers several benefits over the standard non-robotic knee. It is supposed to reduce the likelihood of injury to the soft tissue surrounding your knee joint during surgery because of its increased accuracy. Certainly less dissection is required, and less bony work is required. We don't have to do as many drill holes like you do with a conventional knee. So I think there is some reduced pain. So you may not need as much pain medication after your operation. Potentially there's the opportunity for a shorter stay in hospital and a quicker recovery, so you can get back to your routine. The long-term aim, of course, is that we hope that it provides better function than a standard knee replacement. And we know this, we can track this by looking at the patient recorded outcome measures and the functional outcome scores that I alluded to earlier with the My Mobility app. So how does it all work? So basically everything is pretty much the same, other than 2 pins that are fitted into your tibia and 2 pins into your femur, and on those pins some sensors are attached, or tracker probes, and those tracker probes communicate with the robot, which has a camera in theatre, and it means that when your knee is moved around in space, that it can track it, because we've registered some important landmarks to ensure that it knows where it is in a 3-dimensional space. So at the beginning of the op, we do what's called an initial knee state evaluation, where we see how much you can extend your knee, what the deformity is, how much you can flex your knee, and then we strain and test the different ligaments in the knee to see whether the deformity can be corrected, or whether it's a fixed deformity. All that information is then fed into the robot, and on the computer screen you can see in the picture there, a preoperative plan is produced. We then pause for a bit and have a look at the plan and see where various tweaks need to be made to make sure that the knee replacement is customized to you and is balanced in both flexion and extension, so it has a feeling of security with every step that you take. Once that we're happy with the preoperative plan, that gets saved, and we move to the next step. And the next step is when the ROSA arm comes into view, and it comes down and it's fixed onto the femur with some pins, and on the arm is the cutting jig, and it's that's fixed onto the femur. It has to be placed in the precise position that the computer or the robot wants it to be placed. If it's not, then we can't proceed. Once it's pinned, the surgeon then cuts the bone in the conventional manner. The pins are then removed and the robot arm is swung out of the way. And then we validate the cut that we've made with the computer. And it's so accurate. It's usually within 0.5 degree or 1 millimeter, and sometimes it's spot on. Once it's been validated, the computer or the robot lets us move on to the next step, and we follow that pattern, validating every cut as we go until we've done all of the bony cuts that a knee replacement needs. Once that's happened, we fit the trial knee replacement into place and then do another knee state evaluation checking how the trial knee replacement functions against our preoperative plan. And most of the time, nearly all the time, in fact, it matches the plan. And the deformity is corrected and the knee feels stable and it has a good range of motion. Once we're happy with that, essentially the robot has served its purpose, and we then remove the trial implants and cement in place the knee replacement that we've planned all along for you. And if you wish, right at the end, the final real knee replacement is then evaluated to check that nothing has changed, and it shouldn't have. Once that's happened, the pins are removed and the knee is closed up with sutures and clips and dressings in the conventional fashion. So the surgeon still does the operation, but is assisted in its accuracy by using the robot to ensure that the bony cuts are precise and that the surgical plan is carried out precisely to match the preoperative plan. So we use this data to make more informed decisions, and we can tailor make the surgery to your individual needs. I've just talked about that. Does the robotic arm perform the surgery? No, it doesn't. We still perform the surgery, but the cutting guide is positioned precisely by the robotic arm. Is the ROSA knee system right for me? Everybody's knee is different, but I don't think there should, from memory, I don't think there are any contraindications to say it shouldn't be good for anyone. It's certainly very useful for those who've had previous trauma to their knee or to their femur or their tibia where the bone is healed in an incorrect fashion, because that makes conventional knee replacements very difficult. So the ROSA has a role with the deformed femur and tibia patients, but any arthritic knee is suitable for the ROSA. It's even being used in some centres for revision surgery as well. Obviously, it's important to have a discussion with your surgeon about whether you wish to proceed with it or not, and to check suitability. There's a short video here about how it works. I think I have to click on it with the mouse to make it play. So that's the initial evaluation. So that concludes the talk. There are a few decision support tools to be viewed here that will help you help you with your decision making. Well worth having a look at those. So we'll move on to the question and answer
Yeah,
session
lovely.
now, I
Thank you,
guess.
Mr. Oliver. Very interesting. So actually, some of these came through initially while you were talking about injections. And Helena is asking how steroid injections actually relieve the discomfort caused by osteophytes getting trapped in the joint space.
So the steroid injection really works by reducing inflammation in the knee due to synovial lining being inflamed. If you've got a bit of bone that's trapped in the joint space, I don't think the steroid injection will be particularly effective. Certainly if it's a loose body, that would ideally need to be removed. There aren't usually any osteophytes actually on the weight-bearing surface. They're normally on the periphery of the knee, on the outer edge of the tibial plateau or on the femoral condyles. They're not actually on the weight-bearing surface.
Okay, thank you. And actually, I think Kathleen was referring to Arthrosamid. So I'm missing the pronunciation now. So she was actually asking, this was when you were talking about the 4-year effectiveness. So I guess she's asking why it actually seems to stop around that time, but also why you inject into one spot or whether you do or not.
Okay, so they're interesting questions. I can't tell you categorically why does it stop working. I guess over time its effectiveness just declines. It's supposed to be non-biodegradable, so they're forever. But I guess other areas of the synovium start to become inflamed, and the arthrosamid has already been taken up elsewhere in the knee and not on that particular spot. What happens to the substance when it stops working? It continues to be bound to your synovium and just stays there. And why do we only inject in one place of the knee? There's no real need to inject anywhere else as long as we're in the knee joint, because once you get up from the couch and move around, the arthrosamid washes around the knee joint and goes to the various areas of the knee. But you can certainly inject in other places. It doesn't have to be solely in one place, but there's no need to inject in multiple different sites.
Okay, Grant, thank you. I'm not sure what Graham's situation is, but perhaps maybe he's suffering from an arthritic knee and he's asking what the best exercises are for a painful arthritic knee.
It would be light load-bearing exercises such as walking on flat, even ground, cycling, aqua aerobics, bit of swimming, and also I would recommend some strengthening exercises such as leg raises, hamstring curls, and so on. What you need to avoid is a heavy impact exercise and a lot of pivoting and changing direction and walking on uneven ground where you jar your knee, because that won't help at all.
Okay, thank you. So we've got a question here. I'm 63 and have been referred to have a total knee replacement by an NHS consultant. You mentioned that this is not the age you recommend, but
yeah, that's a good question. It's tailored to the individual. So the youngest patient I've operated on for a knee replacement is 28.
Wow.
And the oldest is I think 98. Yeah, it's 98. Age is just a number, really. If the patient has got an extremely arthritic knee and they're really suffering, then and you're 63, then that is the right thing to do. It isn't the right thing to do if you're 63 and your knee x-ray doesn't show bone on bone arthritis and you haven't exhausted all conservative methods first. You just have to be counseled appropriately and carefully by your surgeon so your expectations are met. It's not a silver bullet. There will be some restrictions to the activities that you may wish to do, but if all goes to plan and you work hard on your exercises, you can return to most activities, and that even includes recreational racket sports in a doubles capacity, and some people have even managed to get back to the ski slopes, but that obviously has added risk. So there you go.
Yeah, absolutely. Thank you. So David's asking, how do you determine if Arthrosamid is the correct solution for the patient? But also, After an injection has been given, how soon can he fly?
So to answer part one, I think Arthrosamid is a good treatment choice for the mild to moderately arthritic knee, and has limited indications in a very arthritic knee, but I think it still has a role to play. I will determine whether it's suitable for a patient after examining them, taking a history and looking at the x-rays. And if the knee has some local warmth and an effusion, which indicates that the synovial lining is inflamed, that's another indicator to me that the injection may be of benefit. With regard to the 4-hour flight, no hard and fast rules about that, but I would certainly probably wait a couple of weeks before you take a long haul flight, because I think it'd be quite uncomfortable to sit in a chair for a prolonged period in the first couple of weeks.
Okay, fantastic. Gordon's asking, some reports suggest Arthrosamid injections are less successful for over 70s. This ties in nicely with the patient you mentioned earlier.
Yeah,
do you have a view on this?
Yeah, I've seen those reports. It's on the it's in the company data and on their website. Actually, they say that the success rate, or the pickup rate of success is I think it drops to about 60 to 63% in the over 70s from memory. But that's still good odds, 63%. And I'll share with you, I saw a lady today who I provided this injection for 4 weeks ago. And the rep said, don't bring her back too soon. It will take about 8 to 12 weeks to work. But I saw her early because she's going on a long haul flight and a long holiday, so she wouldn't be available for follow-up. And after 10 days, she noticed that her knee was much more comfortable, and she stopped taking analgesics and has even managed to play a bit of golf, which she hadn't been able to do for ages. And she is 74 years of age, so that was very encouraging.
Good. No, that's a nice story, that. Robert's asking, is MRI the usual, I guess, diagnostics prior to a knee replacement?
Not usually.
Okay.
Plain X-ray is fine. That will tell the surgeon all that one needs to know. However, an MRI is useful for a patient-specific knee replacement, which sort of precluded the ROSA robot technology. There used to be quite popular a few years back. It was called the signature knee, again by Zimmer Biomet, using the Vanguard knee replacement. And the MRI helped plan for special molds to be produced that are fitted on the knee to produce the bony cuts. But ROSA has superseded that now. You can get an image-based ROSA operation done, and that's taken from special X-rays and I think CT scans. But the image-less ROSA knee replacement is just as good, and that's what we utilise here at Benenden.
Fantastic. Now we've got Tim asking, does bone-on-bone evidence mean that the replacement is probably more appropriate than continuing with any injections?
Probably on balance, because I think the injections are going to be less effective, but it all depends on where you are in your life and what's going on, I guess. You may be too busy to have a knee replacement because of personal circumstances and work circumstances. So therefore an injection will be okay to tide you over. But as I say, I think they'll become less effective. Some patients are medically infirm to have major surgery like a knee replacement. So injections are very useful in that category of patients.
No, fantastic. We've got an anonymous question here, but they are a runner. I am actually having a Vanguard knee replacement next month, but wasn't aware of the ROSA option. I'm 54. Would there be any benefit of having a ROSA option, firstly? And then she goes on to ask whether she could potentially continue to run post-knee replacement.
So, so if you wish to have the ROSA option, then it's not too late to express that wish, especially if you're having surgery with us here. if you wanted the latest technology, then that is the way to go. And being only 54, you would want to make sure that the knee replacement was the best that you possibly could be. There's nothing wrong with a conventional knee replacement, don't get me wrong, especially in experienced hands. But if you wanted cutting edge, the latest technology, then certainly the ROSA option should be discussed, so you're fully aware of it. With regard to running, not many people get back to running after a knee replacement. Maybe some sort of light jogging on soft parkland, but not running. I've had patients who have been able to get back to reasonably competitive levels of squash, tennis. I've had a few patients that have gone skiing, horse riding, but not many that I can recall that have been running.
Okay, thank you. So we've got Lynn asking, I'm guessing this might be related to Arthrosamid because of the timeline she's talking about, but can you have more than one injection after 3 or 4 years?
I believe that is the case. Yeah, it can be repeated. That's correct.
Yeah, brilliant, brilliant. We've got an anonymous one here. What is the advantage of Durolane over steroid injections?
They're two totally different things, really. Durolane works by increasing lubrication in the knee. It doesn't really have any direct pain killing ability. It's it reduces friction between the worn out surfaces. Steroid has an anti-inflammatory effect in the knee. I guess the only advantage that comes to mind is that with a steroid, if you have too many of them, it is actually counterproductive because it can have a corrosive effect on the articular cartilage. And steroid also reduces the local immunity of the area, so slightly increases the risk of infection.
Okay, thank you. Pamela is asking, where there is a significant leg length difference, will this cause problems with a potential knee replacement?
Yeah, that's an interesting question again. Potentially so. So that would have to be assessed carefully to see whether anything can be done to address that. And if it can't, because you certainly can't lengthen your leg or shorten your leg, particularly with knee replacement surgery. But if you couldn't rectify the problem, then various shoe wear and foot raises and things like that to go in the shoe would have to be used to ensure that there isn't too much discrepancy. Otherwise, you would just rock on the leg, I guess. And yeah.
Okay.
Yeah, it has to be assessed on an individual matter.
No, absolutely. I bet. Now we've got Anthony asking. Now Anthony suffers from COL and therefore is immune compromised. He's taking oral chemo. In a recent consultation with an NHS surgeon, he was told there's a 25% risk of infection, and that if the infection occurred, he might need an amputation. Was the consultant conflating risk with consequence?
Certainly, it would be a very high risk to have a knee or hip replacement or any operation that requires the permanent insertion of a metal implant into you, because the metal implant has no blood supply. And if an infection was to take hold, it grows what's called a biofilm over the implant, which antibiotics can't penetrate, because the antibiotics need a blood supply to work. So the only way of eradicating the biofilm is to physically debride it and scrub it. And even that isn't particularly effective. So I can understand why the NHS orthopaedic surgeon was very cautious. 25% risk of infection seems a little high, but certainly the risk of infection would be greater than the 1% national average. I can't give you a figure, but I would prefer my patients to be off all immunotherapy and all steroids, ideally, and all chemotherapy before having the operation.
Okay, thank you. We've got a question here. This person has an elderly relative in their 80s with very severe arthritis. They've been assessed not medically fit for a knee replacement due to arterial fibrillation. Would Arthrosamid be an option?
I certainly don't think it would do any harm. It may help. As we alluded to earlier, the older the patient and the more severe the arthritis, the less effective it may be. But even if it was to diminish the pain 10, 15, 20%, that would still be a benefit to the patient.
Absolutely, yeah.
And it's minimally invasive. There's no immunocompromising material in it. Yeah, so it shouldn't, yeah, it's worth a go.
Yeah, absolutely, absolutely. We've got Adrian asking that his 65-year-old wife had a traumatic injury to her knee 6 years ago and was left with valgus deformity and pain. The consultant advised previously that her knee should be replaced when osteoarthritis sets in, but they're unaware if the pain is down to the previous injury or is osteoarthritis. How can they tell?
That's another good question. It would need to be properly evaluated with a good history, an examination, and a set of weight-bearing X-rays. It's probably a combination of both. The previous injury has now led to what's known as secondary osteoarthritis. Yeah, that's how we would tell.
Okay, thank you. We've got quite a lengthy one here from Jill. So Jill's been told that she has limited, where are we? So regarding injection, she's been told that she has limited space in order to inject into her knee as her arthritis is very advanced. She has a damaged tendon that is causing her problems. Now, along with her arthritis to the tendon injury, she was coping well. I also use lipodema, which means I have very heavy legs that's due to all of this. I've been told infection is a real issue.
So there's a few problems going on here, isn't there? So lymphedema or lipodema makes knee replacement surgery a little bit more challenging because the leg is very swollen to start with and only swell more after the operation. And the patient needs to be counselled about this because it usually makes the exercises very challenging and therefore the knee becomes stiff, which is not ideal because that's poor function and you've just gone through all that and you've got a stiff knee. With regard to the injections, that's the beauty of using an ultrasound. If the probe is sensitive enough, we should be able to scan through the lymphedema to ensure that the injection goes into the correct place into the joint and therefore provide the injection correctly positioned and therefore hopefully it will work.
Yeah, no, absolutely. Thank you. So Marilyn's asked that she's had an arthroscopy and various steroid injections already. She's had her follow-up appointment, but still too soon for a replacement, apparently. She's had I've had pain elsewhere. So she's had 5 other injections at another clinic in her knee, but no idea what they were called. She still has pain to the left of her knee, which she believed might be a sciatic issue. Are there any things that you can maybe suggest?
If you think it's sciatica, which is a trapped nerve in the back, then the best way of having that ruled out is to ask for an MRI of your lumbar spine. That will tell us whether you've got trapped nerves. Also, weight-bearing X-rays of the knee will be able to tell us what stage in the arthritic process that you're at, and then we could manage it from there. If you've had all these injections and then the pain is still there, that does concern me somewhat. Either the injections are not hitting the spot and are going into the fat or the soft tissue, not the joint, or you've got a trapped nerve, like you say, the sciatica. So yeah, further workup required.
Yeah, absolutely. Exactly. Give us a call. I'll tell you what, we're going to answer these last 2 because we are running out of time, and we definitely don't want to make sure we're not snowed in. So this is the lady from Prior, and she's actually asked, would I need to discuss the ROSA option prior to our operation, or can she decide on the day?
I would certainly recommend that you discuss it pre-op. Come in and have another appointment with one of us.
Yeah.
Because it's a big deal, not only for you financially, but also it's a different setup, and you just need to be fully informed.
No, absolutely. And this one actually interested me, so we'll finish with this one. If you have one very painful knee and the other not so painful, is it better to have Arthrosamid in both knees together?
I haven't done two knees at the same time, but it can be injected. You can have bilateral injections. So that's a good question, actually. I would probably wait to see if you responded to one injection first before having the second one done. Not only because it's financially quite pricey, but also you just want to see if it actually works for you or not.
Yeah, absolutely.
I just have one done at a time personally.
Okay, no, that makes perfect sense. Makes perfect sense. Right, so thank you for that, much appreciated. If we didn't get to answer any of your questions, if you did provide your name, we will be able to get back to you via email. So we need to close that there. If we can just move on to the next slide. Okay, so thank you ever so much again. As a thank you for joining this session, we will be offering 50% off the value of your knee pain consultation, and that will be available for 7 days. Call back from our dedicated private patient team advisor, an email with a recording, treatment information, and loyalty reward points, and update on news and future events. We would be really grateful if you could complete the survey at the end of the session, as this helps us shape future events. If you'd like to discuss or book your consultation, our private patient team can take your call up until 8 p.m. tonight, or between 8 and 6 Monday to Friday, using the number on the screen. We've had more events and webinars coming up in hip surgery, urology, and varicose veins, which you can sign up to via our website. So, on behalf of Mr. Matthew Oliver and the expert team here at Benenden Hospital, I'd like to say thank you for joining us, and we hope you have a lovely evening. Thank you.
Thank you. Thank you very much.
Thank you.